Good afternoon, everyone. My topic for today's presentation is dopamine and its relevance in psychiatry. And my moderator is Dr. Rupali ma'am. This is an overview of the topics that we will be going through today. First, there will be an introduction. Then we will talk about the synthesis of dopamine, the termination of dopamine, dopamine receptors, dopamine pathways, a little about dopamine receptor agonist, dopamine receptor antagonist, and finally, we will make a mention about dopamine in psychiatric illnesses. Now, dopamine, it is a monoamine, and dopamine neurons, they are more widely distributed than those of other monoamines, residing in midbrain substantia nigra and ventral tegmental area, and in the periaqueductal gray, hypothalamus, olfactory bulb, and retina. In the periphery, dopamine is found in the kidney, where it functions to produce renal vasodilatation, diuresis, and natriuresis. First, we will talk about the synthesis of dopamine. Now, dopamine, it is produced from tyrosine. It goes inside the presynaptic neuron via the tyrosine transporter, and then it is converted into dopa via tyrosine hydroxylase. Then dopa, it is converted into dopamine via dopamine decarboxylase enzyme. And finally, this dopamine, it goes inside the synaptic vesicles via the VM82 receptor. Next, termination of action of dopamine. It is a little different in striatal dopamine terminal and in cortical dopamine terminal. In striatal dopamine terminal, there is a dopamine transporter which again reuptakes dopamine into the presynaptic neuron, where MAO A or MAO B, it will destroy dopamine. Also, in the extracellular area, there is a catechol O-methyl transferase enzyme which will destroy dopamine. In cortical dopamine terminal, the amount of dopamine transporter, it is less. So the main mechanism of action of termination is via catechol O-methyl transferase, and some of the dopamine, it also diffuses, and it is and reuptake occurs by norepinephrine transporter enzyme. Next, we will talk about dopamine receptors. Now, dopamine receptors, they are postsynaptic dopamine receptors. They are of two types. They are D1-like receptors and D2-like receptors. D1-like receptors include your D1 and D5, which are excitatory in nature, and they will stimulate the postsynaptic neuron. While D2-like receptors, they are D2, D3, and D4, and they inhibit postsynaptic neuron. Now, presynaptic dopamine receptors are your D2 and D3 receptors, and they are mostly inhibitory in nature. So they will act as autoreceptors, and they will inhibit the release of dopamine. Now, dopamine pathways, the classical dopamine pathways, they are usually 5. First is nigrostriatal dopamine pathway, which goes from the substantia nigra to the striatum area. The second is your mesolimbic pathway. Mesolimbic pathway, it is from your ventral tegmental area to your nucleus accumbens. Third is your mesocortical which goes from your tegmental area to two areas, that is your dorsolateral prefrontal cortex and ventromedial prefrontal cortex. Then is your tuberoinfundibular, which goes from your hypothalamus to the pituitary area. And the fifth area, it arises from multiple sites, including periaqueductal gray, ventral mesencephalon, hypothalamic nuclei, lateral parabrachial nucleus, and projects through the thalamus. Now, first we will talk about tuberoinfundibular pathway, which uh, which is from the hypothalamus to the pituitary area. Now, these neurons, they are tonically active and they inhibit prolactin release. In the postpartum state, however, the activity of these dopamine neurons is decreased, and the functioning of these dopamine neurons can also be disrupted by lesions or drugs. And in such cases, the prolactin levels rise, and elevated prolactin levels, they are associated with galactorrhea, gynecomastia, amenorrhea, and possibly other problems such as sexual dysfunction. Now, thalamic dopamine pathway. Now, this is a relatively newly discovered pathway which arises from multiple sites, including periaqueductal gray matter, ventral mesencephalon, from various hypothalamic nuclei, and from lateral parabrachial nucleus. Its function is still under investigation, but it may be involved in sleep and arousal mechanisms. Then is nigrostriatal pathway, which goes from the substantia nigra to the striatum. Now, classically, this has been considered to be a part of extrapyramidal nervous system and controls motor movements via its connections with thalamus and cortex in striatothalamo-cortical circuits or loops. Deficiencies of dopamine in these motor pathways, they cause movement disorders, including Parkinson's disease. Dopamine deficiency in striatum can hypothetically also be involved in mechanism that produces akathisia and dystonia. And these same movement disorders, they can also be replicated by drugs that block T2 dopamine receptors in this pathway, causing drug-induced Parkinsonism. Hyperactivity of dopamine in nigrostriatal pathway is thought to underlie various hyperkinetic movement disorders like chorea, dyskinesias, and tics. And chronic blockade of these same dopamine D2 receptors in the nigrostriatal pathway, it is hypothesized to cause another hyperkinetic movement disorder, which is called as tardive dyskinesia. Now, this diagram, it shows the dopamine regulation of direct and indirect pathways. Now, your substantia nigra, now the dopamine receptors, D1, we know it is excitatory in nature. So it will further stimulate it will cause stimulatory action and will cause your motor movement. While D2, it is inhibitory in nature. So it is an indirect pathway which further which inhibits these motor. Third is mesolimbic dopamine pathway. Now, mesolimbic dopamine pathway, it extends from the ventral tegmental area and brainstem to nucleus accumbens, and this is responsible for motivation and reward. Overactivation of these pathways will cause the drug-induced high, as we know it, and may also cause the positive symptoms of psychosis. If there is inhibition of this mesolimbic dopamine pathway, it causes negative symptoms, anhedonia, apathy, and lack of energy. Next is your mesocortical dopamine pathway. Now, it goes to the dorsolateral prefrontal cortex, where it is mainly responsible for executive and cognitive functions. If it is if the dopamine is low in this pathway, it will cause negative symptoms and cognitive symptoms. While the pathway to ventromedial prefrontal cortex, it is responsible for emotions and effect. So if dopamine is less in this pathway, it will cause negative symptoms and affective symptoms. Now we will talk about dopamine receptor agonists, which activate dopamine receptors in the absence of endogenous dopamine. The drugs in this class, which are commonly prescribed, are bromocriptine, levodopa, carbidopa, levodopa, and amantadine. And new dopamine receptor agonists, they include ropinirole, pramipixole, apomorphine, and pergolide. The therapeutic indications for these agonists, First is medication-induced movement disorders. Uh, they are used in the treatment of medication-induced Parkinsonism, extrapyramidal symptoms, akinesia, and focal perioral tremors. They're also effective in treating idiopathic restless leg syndrome and may also be helpful when this is a medication side effect. Propranolol has an indication for restless leg syndrome. Bromocriptine, it remains in use for the treatment of neuroleptic malignant syndrome, and they can also be used to counteract the hyperprolactinemic effect of dopamine receptor antagonists. Second is their use in mood disorders. Now, bromocriptine has been used to enhance response to antidepressant drugs in refractory patients. Propranolol has been reported to be useful as augmentation to antidepressant therapy and as a treatment for medication-resistant bipolar II depression. Propranolol, it may also be helpful in the treatment of antidepressant-induced sexual dysfunction, and pramipexole is often used in augmentation of antidepressants in treatment-resistant depression. Next is in sexual dysfunction. It improves erectile dysfunction in some patients, but they are rarely used because they frequently cause adverse effects at the therapeutic dosage. Next is precautions and adverse effects. The adverse effects are mostly dosage dependent. They include nausea, vomiting, orthostatic hypotension, headache, dizziness, and cardiac arrhythmias. They should be used with caution in patients with hypertension, cardiovascular disease, and hepatic disease. After long-term use, people which are particularly elderly population, they may experience coliform and dystonic movements and psychiatric disturbances, including hallucinations, delusions, confusion, depression, and mania, and other behavioral changes. Long-term use of bromocriptine can produce retroperitoneal and pulmonary fibrosis, pleural effusions, and pleural thickening. And they're also contraindicated during pregnancy, especially for nursing mothers, because they inhibit lactation. Now, dopamine receptor antagonists, the indications for these are acute psychotic episodes in schizophrenia and schizoaffective disorder, maintenance treatment in schizophrenia and schizoaffective disorders, mania, depression with psychotic symptoms, delusional disorder, borderline personality disorder, substance-induced disorder, delirium and dementia, mental disorders caused by medical condition, childhood schizophrenia, pervasive developmental disorder, Tourette's disorder, and Huntington's disease. Now, as we know that in untreated schizophrenia, mesolimbic and mesostriatal pathway, they cause the positive symptoms. If we give D2 antagonist, the therapeutic effect of these will be that they will reduce the positive symptoms. But the side effect will be that secondary negative symptoms, that is apathy and anhedonia, will rise. In mesocortical pathway, they are when there is hypofunction of this pathway, it causes negative symptoms and effective symptoms. Now, D2 antagonist, they will worsen the cognitive symptoms and the negative and the effective symptoms of the patient. Now, tuberoinfundibular, now D2 antagonism and tuberoinfundibular pathway will inhibit it, so it will cause rise in prolactin levels. And in nigrostriatal pathway, the D2 antagonism will inhibit this pathway. It will cause akathisia, drug-induced Parkinsonism, and dystonia. Now, precautions and adverse reactions. First is neuroleptic malignant syndrome. Now, this can occur at any time during the course of dopamine receptor antagonist treatment. Symptoms include extreme hypothermia, severe muscular rigidity, dystonia, akinesia, mutism, confusion, agitation, and increased pulse rate and blood pressure. Lab findings include increased white blood cell count and increased levels of creatine phosphokinase, liver enzymes, plasma myoglobin, and myoglobinuria. It is also occasionally associated with liver failure. The symptoms usually resolve over 24 to 72 hours, and the untreated syndrome lasts 10 to 14 days. Now, they usually lower the seizure threshold, and the risk of inducing a seizure by drug administration warrants consideration when the person already has a seizure disorder of brain lesion. Third is sedation. Now, blockage of histamine receptors is the usual cause of sedation associated with dopamine receptor antagonist, and giving the entire daily dose at bedtime usually eliminates any problems from sedation, and tolerance for this adverse effect often develops. Next is central anticholinergic effects, which include severe agitation, disorientation to time, place, and person, hallucinations, seizures, high fever, and dilated pupils. Next is cardiac effect. They usually decrease cardiac contractility, disrupt enzyme contractility in cardiac cells, increase circulating levels of catecholamines, and prolong atrial and ventricular conduction time and refractory periods. Now, occasional reports of sudden cardiac death during treatment with dopamine receptor antagonist. This may be the result of cardiac arrhythmias, and other causes may include seizure, asphyxiation, malignant hypothermia, heat stroke, and neuroleptic malignant syndrome. Next is orthostatic or postural hypotension. Now, this is most common with low potency drugs, particularly chlorpromazine, thioridazine, and chlorprothiazine. Now, hematological effects. Agranulocytosis, which is a life-threatening hematological problem. It occurs in about 1 in 10,000 persons treated with dopamine receptor antagonist. Thrombocytopenic or non-thrombocytopenic purpura, hemolytic anemias, and pancytopenia may also occur rarely in patients treated with dopamine receptor antagonist. Next is peripheral anticholinergic effects, which consist of dry mouth and nose, blurred vision, constipation, urinary retention, and mydriasis are common, especially with low potency dopamine receptor antagonist, for example, chlorpromazine. And weight gain is associated with increased mortality and morbidity and with medication non-compliance. Next is endocrine effects. Now, blockage of dopamine receptors in the tuberoinfundibular tract results in increased secretion of prolactin. It can result in breast enlargement, galactorrhea, amenorrhea, and inhibited orgasm in women and impotence in men. Sexual adverse effects. Now, both men and women which are taking dopamine receptor antagonist, they can experience anorgasmia and decreased libido. Skin and eye effects, allergic dermatitis and photosensitivity may occur, especially with low potency agents. Along with this, urticaria, maculopapular, petechial, and edematous eruptions may occur early in treatment, generally in the first few weeks, and remit spontaneously. And also elevations of liver enzymes during treatment with dopamine receptor antagonist. It tends to be transient and not clinically significant. Here we make a mention of dopamine and major psychiatric illnesses. First, as we have discussed, it is implicated in schizophrenia. Second is Parkinson's disease, which we know it is a progressive neurodegenerative disorder, which is associated with loss of dopaminergic neurons, is substantia nigra pars compacta. And the hallmark of this disease are its triad of motor features, which is resting tremor, rigidity, and akinesia, bradykinesia. Gait and postural disturbances also characterize this disease. Now, in substance abuse, now chronic exposure to addictive drugs causes a homeostatic impairment of dopamine system, in which natural rewards, which are your food, water, sex, or social companionship, they become less effective at increasing dopamine release in a typical fashion. These homeostatic changes, they are thought to contribute to negative affective states observed between periods of drug taking or during periods of drug withdrawal and abstinence. And it's also observed that chronic intermittent drug exposure, it can sensitize the dopamine system such that exposure to the drug or drug-associated stimuli elicits greater increases in dopaminergic transmission. This sensitization of dopamine response can persist long after the drug taking ceases and may relate to drug craving and relapse. Now, in mania, essentially all drugs with D2 antagonists or partial agonist properties, they are effective in treatment of acute bipolar mania and in preventing recurrences of mania. It has also used an antidepressant action in bipolar and unipolar depression, agitation and dementia, sedative, hypnotic, and sedating action is also there. These are my references. Thank you.